Our next speaker is Dr. Michael McGuire. He's authored over 50 scientific articles in textbook chapters. He has been past president of the American Academy of Periodontology and the American Academy of Periodontology Foundation. In addition to being in full-time private practice while providing all this fantastic research that's won numerous awards. Dr. McGuire is going to be speaking to us this morning on soft tissue biologics.
Thank you, Dr. Nevins, and thank you to the Academy of Osseointegration for the opportunity to share some of our recent research that we've been doing on soft tissue engineering. And I'd like to share with you what we've been doing in creating keratinized tissue with living cellular constructs. But perhaps before we begin that, maybe we should set the stage. Do we really need keratinized tissue around implants? You know, that's a question that a lot of us have been asking for many, many years. And if we look to the literature and we ask the question, does the width of keratinized gingiva influence the dental health status of the supporting tissues around dental implants, we find that whatever answer you're looking for, it's out there. There's a group of studies that suggest, yes, keratinized tissue is important. Another that say, nah, you don't need it. And a third group that says, well, maybe. And you know, that's for a lot of reasons. You know, periodontists seem to think that keratinized tissue is more important than oral surgeons, although we're getting a few converts. Americans seem to think it's more important than Europeans. A lot of the early work was negative that you don't need keratinized tissue because early implant-supported restorations were supported on titanium stilts, where the restorations were, you know, a considerable distance from the mucosal interface. But now most implant-supported restorations are approaching or entering the mucosa. And as that happens, new inflammatory challenges are emerging. But let's look at the literature that we have. For that group of papers that state that it's not important, they conclude that peri-implant soft tissue parameters show weak correlation to crestal bone loss, that peri-implant health can be maintained without keratinized tissue in the presence of good home care. Most of my implant patients, or a lot of them, don't have good home care. That's why they have implants. Lack of keratinized tissue was a poor predictor of recession, and maintenance of implant health is possible without keratinized tissue. Well, it's also possible I might win the Florida lottery today, but as a clinician, I don't want to know what's possible. I want to create an environment that will allow the maintenance of health to be more predictable in my patients. If I look at the group of studies that say, yeah, it may be something we might want, they suggest and conclude that the absence of keratinized tissue was associated with increased plaque score and bleeding on probing, but not alveolar bone loss. But you have to remember these are short-term studies, most of them. There was no correlation found between keratinized tissue and inflammation, but recession, probing pocket depth, probing attachment level were slightly influenced by the amount of keratinized tissue. So it seems in these papers that at least the width of keratinized tissue seems to give more resistance to probing. And then finally, the group of papers that suggest that keratinized tissue is important conclude that less than 2 millimeters of keratinized tissue was associated with significantly more recession, plaque, gingival index, and bleeding on probing, that an increase in bleeding on probing was found even after factoring in the time since implant placement, smoking, thickness of gingiva, and plaque index, and finally that the mean bone loss was greater for implants with a narrow zone of keratinized tissue. So basically they're concluding here that if you don't have a sufficient zone of keratinized tissue, your patients are going to be more at risk to insult. Now, this is a controversial topic, whether you're talking about teeth or you're talking about implants, but it seems that it may be even more important around implants than teeth, because the peri-implant tissue is different than the periodontal tissue as it relates to the resistance to bacterial infection. And that's primarily because we have a different attachment apparatus, don't we? We have in implants a supracrestal attachment apparatus where we have parallel collagen fibers rather than the periodontal attachment apparatus that we have around teeth, with a perpendicular attachment, and the entire attachment apparatus around teeth is more resistant to mechanical injury and to bacterial infection. You compound that with the fact that almost all implant-supported restorations are submucosal. So they're going to be in that area that you have to pay more attention to inflammation and infection. And if you get into trouble, what happens? It's more difficult to get out of trouble around implants. It's more difficult to regenerate and repair, whether it's soft or hard tissue around implants. We have less cells. We have less vascularity. So again, as a clinician, I want to stay away from that. I'd rather be proactive. I don't want to get in trouble. So let's go back to the literature. What's our conclusion today? Well, we're going to base our conclusions on the evidence, but also on our clinical judgment. And, why do we have, all of these different answers out here? Well, it's for a lot of reasons. One, the statistical methods are different in these studies. The endpoints are different. A lot of them are just small case series with a low N. We also have retrospective and prospective studies that really don't have any controls. So at the end of the day, you and I are going to have to make a decision. Until there's randomized controlled trials, there's not going to be a definitive answer. And until we have a definitive answer, as a clinician, I want keratinized tissue around my implants. And if I need keratinized tissue around my implants, I'd like to be able to have an off-the-shelf source to allow me to do that. So that's what we're going to talk about, how we can create site-appropriate keratinized tissue around teeth and implants using living cellular constructs. I think it's appropriate to disclose that I am a paid consultant for Organogenesis, but I always maintain complete control of the content of my lectures and reporting of all data. Now, when I think about tissue engineering, I like to think about it as a broad matrix. On one end, down here, we've got live cells, and here we've got bioactive molecules. And really, why do we even need tissue engineering? Well, if you have a bigger defect, like Dr. Herford was showing, you can't expect the body to heal that. You have to have something to jumpstart the body's ability to heal. So the way we've gone about that in tissue engineering is traditionally we have looked for a biologically active molecule to do that. So the theory is you and I need to discover what's the appropriate biologically active molecule. We need to decide how can we deliver it to the site at the appropriate concentration for the appropriate strength for the appropriate length of time. And if we can do that, it causes the cells from around the defect to migrate in, to differentiate, to proliferate, and finally to participate in the regenerative process. And we've heard throughout this conference about all sorts of potent biologically active molecules. And many of us have placed them into the defect, and we've stood back and waited for magic to happen. But magic doesn't always happen, and why is that? Even though we know these are potent biologically active molecules. Because the reason magic doesn't happen sometimes is there are so many variables that we have to control. How do we know that really the molecule got there? How do we know it stayed there long enough? How do we know the concentration was enough? Maybe it was too much. Maybe it wasn't enough. All of that can influence the end result. The attractive part of this end of the tissue engineering spectrum, the live cell end, is that these are living cells. And through surface receptors, they're talking to each other, they're talking to the native environment, and theoretically, they have the potential to deliver these cytokines and much more on demand. And as you begin to think about live cell-based devices, you have to change your mindset. We're not talking about tissue replacement grafts here. You have to change the way you think about grafts and your expectations of them. With these living cellular constructs, they're bringing not only the cytokines, but they're bringing cells, they're bringing collagens, and they're bringing glycosaminoglycans, all the things necessary for regeneration, and again, most importantly, theoretically, delivery on demand. Now, when you and I are faced with any oral mucosal defect, we have a variety of options on how we might want to manage that. We can treat it through primary intention or secondary intention. Through primary intention, we're going to mobilize a flap, we're going to suture it and close the defect. Or perhaps we're going to close the defect by a graft, where we take our tissue from a remote site and we place it in. Either way, we're closing it through primary intention. The other option, secondary intention. We don't do that too much anymore, do we? Well, it takes longer, there's more inflammation, there's more pain associated with it, and so that's fallen out of favor. But regardless of whether you are going to manage your oral mucosal lesion through primary intention or secondary intention, there is a spectrum of wound healing. And what we're really talking about here is the quality of healing. On one end of the spectrum, you've got a great big keloid, or you've got a hypertrophic scar like you see here, or you even have a tissue mismatch, from this graft. On the other hand, you have regeneration. We know that kids heal better and faster than adults. We know that fetuses will heal without a scar, and we know that certain animals, you can regenerate entire appendages through an enhanced form of secondary intention. Whether you are looking at any form of regeneration, all forms of regeneration are through an enhanced form of secondary intention, whether you're looking at neonatal or animal or fetal. And when you look at these living cellular constructs, they're not a tissue replacement graft. Anytime you're doing a tissue replacement graft and you place those cells there, those cells stay there forever. They keep their phenotype from wherever they came from. You have the morbidity of the donor sites. You have the limitations of the amount of tissue available. And actually, even closing a defect early through a graft, you can abrogate the body's innate ability to regenerate. Living cellular constructs don't work like that. The cells come in, they enhance and modulate secondary intention, moving it toward that regenerative end of the spectrum. Again, if you look at this big ulcer, you could imagine if you put a skin graft, say from the leg over here, that graft would always stay there. It would always look like that. But look what happens as you get site-appropriate differentiation of the cells. You not only get a closure of the ulcer, but you get the natural pigmentation. So it's a different process. Similarly, in our studies that we've done in the oral environment, if you look here, it's obvious this is just mucosa. There's no keratinized tissue at all, so I've created a bed here. Now, if I'm just placing this living cellular construct here and it's acting like a biologically active Band-Aid that's going to make it heal faster and heal without a scar, I'm going to get exactly what I started with, just faster and without a scar. But that's not how this works. This works by actually changing the trajectory of healing, creating site-appropriate differentiation. In other words, we get keratinized tissue there where we only had mucosa to start. Now, these cells come, they're neonatal cells. We have fibroblasts and keratinocytes. You can see the fibroblasts down here in the collagen matrix and the keratinocytes up here. But the interesting thing, and Dr. Herford mentioned a couple of these kind of things about how you need the synergism. The interesting thing about this material is that if you have keratinocytes by themselves or you have fibroblasts by themselves, you see that they produce some cytokines and not others. Yet if you place them together, they're producing the full spectrum of these cytokines because of the crosstalk and the synergism. And in fact, if you look at some of the cytokines like insulin growth factor here or interleukin-8, that's not produced by keratinocytes or fibroblasts. Yet when they're together, it's producing it. So there's a lot of synergism between these cells. And if you look at all the cytokines that they produce, I just highlighted some that are important in regeneration. You know, again, what's one of the problems that we have? How do we access these biologically active molecules that we're finding are important to us? How do we get these? Well, this is a reservoir for a whole host of ones that we know are important. BMPs 2s and 7s, fibroblast growth factor, TGF, TGF-beta-1, VEGF, all of these. And hopefully we can access them on demand. What's one of the big problems we have as clinicians when we're trying to regenerate and repair? Blood supply. What are all of our surgical guidelines based on? Blood supply. Well, what if we can go in and change our own blood supply into the area? What's one of the big challenges about treating implants that I just mentioned? Blood supply. We don't have a PDL. Well, this material is producing VEGF, it's producing fibroblast growth factor, stimulating angiogenesis, has the potential to rewrite the rules of regeneration and what you and I do on a daily basis. And it also brings not only the cytokines, but it's bringing the extracellular matrix components necessary for cell migration, structural integrity, and inflammation modulation. But I think the most exciting thing is it is dynamic. It's reacting to the environment. One of the things they've done for plastic surgical procedures is mesh the material. So here's how it looks after meshing. And you can see on a gene expression of these particular cytokines that certain cytokines are more active after meshing than they were before. I like to think of it as the material's kind of trying to claw back to life. It's trying to heal. And in fact, in our pilot study, we wounded the material so to upregulate the cytokines as well. And concrete proof that it's a living construct is that if you wound it, it heals. Here's the material with a wound through the epidermis. By 12 hours, you're beginning to see the keratinocytes migrating over. And by 24 hours, you have the keratinocytes that have fully migrated over the surface of the wound. And by 5 days, you have a fully differentiated epidermis and dermis. So we use this material in our studies in a Z-fold. We did it primarily to improve handling capabilities. We had the keratinocytes on the outside, the fibroblasts toward the teeth. And this is how the material comes. It comes currently in a bioreactor like you see here. The living cellular construct is on the top. This was during our pilot study, and I'm striating it now, or wounding it. I remember asking the companies, well, why don't you just wound it before you send it to me? And I won't have to do that. I said, because it'll heal by the time it gets to you. You know, this is kind of wild stuff. And so now I'm separating it from the bioreactor, and we're going to fold it over like you would fold a piece of paper you put in an envelope or a sheet on your bed, because we're creating this Z-fold. You could graft the entire mouth with the amount of tissue that you have here. In the pilot study, we standardized our grafts where we had 5 millimeter wide grafts, both with the living cellular construct and the free gingival margin, our free gingival graft. You're seeing now I'm just confirming I've got 5 millimeters here. And I'm coming in, and we're going to cut this piece out of the bioreactor. We find that removing it with the scissors is a little easier than the scalpel. The scalpel, it kind of drags on it. And now we will, I've already prepared my bed for the patient, so we'll take it to the mouth. Here's the bed. Now, in this pilot study, we're just trying to generate keratinized tissue. We're not trying to do any root coverage or anything. And I'm placing it now on the bed. It's easy to manage. Basically just kind of sucks down to your periosteal bed, and I'll suture it interproximally. So that's our graft. And this is the same patient at a week, at 4 weeks. You can see in the 4-week panel, this is the engineered tissue here and the free gingival graft here. You can see we're beginning to form a mucogingival junction. We're getting nice keratinization. Follow the same patient out to 6 months. On this panel, we've stained with Schiller's iodine stain to differentiate the mucogingival junction, the alveolar mucosa from the keratinized tissue. You see where we're getting nice resistance to muscle pull, a nice functional zone of keratinized tissue. Another patient with the living cellular construct up here, the free gingival graft down here. But if we center on this panel at 6 months, I think you can appreciate the difference. You know, the traditional free gingival graft, you know, very functional. It works. I can do it every day. But you can tell I was in there. And you can plastic that. It's going to come back just like it is, because these cells don't belong there. These cells come from the palate. They will always retain their palatal phenotype. Look at what we have here. A similar amount of keratinized tissue, but a much more aesthetic result, because this is site-appropriate differentiation. These cells belong here. The material causes the cells from the periphery of the defect to migrate in, and we now have appropriate keratinized tissue. Well, we wrote that paper up for those that are interested, and we published that in Journal of Periodontology in 2008. And from the information in the pilot study, we then took that to a pivotal multi-center trial. And the different centers were our group in Houston, University of Texas at San Antonio with Drs. Cochran and Melenig, Michigan with Dr. Gianobili and his group, and Dr. Nevins with his center in Boston. We had some lessons learned from the pilot, and in the multi-center trial, we no longer standardized the width. We decided we're thinking too much like this is a tissue replacement graft. This isn't a tissue replacement graft. It's silly to try to match things up. And so we were able to improve our results. And I think I want you to look here and look here at the two befores. Clearly you can see absolutely no keratinized tissue. You know, you can appreciate the vascularity of the mucosa here. But look what happens after we graft. Here's our free gingival graft. Again, you know, this is a nice result. But certainly tissue mismatch here, right? This is what we would expect. I want you to focus on this. I think this is where we're going. This should be the goal for all of us, that if you know what you're doing with surgical guidelines, you can predict how much keratinized tissue you can get. You can predict how much root coverage you can achieve if that's what you're trying to do. But the next goal is for us to be able to end up with a result that's indistinguishable from what Mother Nature intended. Even master surgeons can create scars, but with this material, can you tell I was even in there? I don't think so. And I think that's where we're trying to go. So we concluded from our multi-center trial that LCC is effective and well tolerated in a non-submerged wound healing environment. We generated a mean of 2.1 millimeters of keratinized tissue. It provided improved aesthetics, greater patient preference, and no donor site morbidity. Well, if you can do it around teeth, how about around implants? Well, I'm old enough to remember that. I remember when we started doing guided tissue regeneration, we wondered we probably couldn't do that around implants because we needed the cells from the PDL to be able to populate that when we placed our membranes. Well, we found out we could do guided tissue regeneration around implants, but how about here? I'm saying this causes site-appropriate differentiation. So are these cells coming from the PDL? Can we do it around implants? But we also we have the same problems here that we're trying to avoid. You know, we don't want this wound on the palate. We want an unlimited amount of donor tissue, and we just don't want to have to do that. And this is a patient, this is an implant here. He has chronic inflammation faced with the implant, having a new implant placed here. So, you know, we harvest our tissue, place it down there to generate a zone of keratinized tissue. And again, it's a difficult situation to manage for lots of us. So here is a patient of mine who moved into my practice a number of years ago with a couple of implants, had a great deal of problems in maintaining these. I think you can appreciate the freely movable mucosa that we have here. It just was hard for her to keep it. It was chronically inflamed. So we go in, I create a partial thickness dissection, as you saw, around the teeth. We place our living cellular construct in here. We're suturing it to place. Again, this is a triple layer like you've seen. And in the pivotal trial, we also placed a fourth layer over it, really just as a buffer between the graft and the packing, because we believe it's important to try to stabilize this material, not only with sutures, but to go in and dress it. So we're dressing it with Copac. And here's what we have at 6 months. I think you can appreciate now we have a firmly bound down tissue here. We have keratinization that makes it easier for her to come in with her proxy brush, with her floss, and keep this area inflammation-free where it was almost impossible with this freely movable mucosa. Another patient where, you know, the two implants that are already existing, Aponic here, you know, the typical kind of not the best home care, and I think you can appreciate mainly just movable tissue. She has some keratinized tissue here, but no attached gingiva. Again, I've just stained it with Schiller's iodine stain there. And when we're doing all of these cases that you've seen, both with the pilot study and the multi-center trial and what we're doing here, we're removing any keratinized tissue that they have as part of our flap. And so I go in, I place our triple layer here, we dress it with Copac, and we're able then to generate a nice zone of keratinized tissue that allows that patient to come in and maintain it even without the greatest home care in the world. So you can't say a lot about this around implants because it was just a very small case series, about 6 patients that we followed over 6 months. But within the limitations of what we've got, we concluded that all patients healed uneventfully with complete epithelialization by 2 weeks. We didn't have any adverse events. The treated sites matched the surrounding tissue both in texture and color. That the engineered tissue was capable of generating up to 4 millimeters of site-appropriate keratinized tissue around the implants without a donor site or a PDL, but obviously a lot more studies need to be done in order to determine predictability, durability, and how can we really leverage this robust device to the best interest of our patient. This material and other generations to come have the potential to be revolutionary, to allow us to do things we couldn't do in the past, to provide our patients treatment with the least amount of morbidity, with the greatest amount of predictability, and allow us to expand what we do into areas that we couldn't have imagined in the past. Thank you very much for your attention.